Good afternoon, everybody. Thank you for being here. Can you hear me? All right, can you see the presentation? All right, so we will finish yesterday's subject and we will get forward on another subject. I hope we can finish today. Next Friday, there won't be a class. So let's begin. As you can recall yesterday, the clotting factors and the end of the coagulation cascade, there are certain medications that we have to provide in order to prevent the formation of thrombi in special cases such as overweight or prolonged immobilization from the patient and so forth. So we have to prevent that. All right, so we give this NFH, which accounts for non-fraction heparins. Non-fraction heparins, what they do is activate antithrombin 3, which then inhibits factor 10. And factor 10, as you can recall, is the final common pathway necessary to form thrombin. Now, these were very good, and most of them, they use this, especially in public hospitals. But in private places, they switched to a newer model of anticoagulation therapy, which is the low molecular weight heparin. And one example of this is the enoxaparin. This, in turn, inhibits factor 10 activated. It has longer half-lives, and we need lower dosages. You can give this once a day, and you inject this subcutaneously once a day. And the other one, you need to give this intravenous, and you need to give infusion to the patient. Whatever the case, whatever is available, you can use it. Now, where are you going to use it? There are some other medications such as inhibitors of thrombin, such as fondaparinux. This medication is not available for usage in Mexico. They're only available in the United States. And there are the so-called inhibitors of vitamin K-dependent factors, such as warfarin. Now, which is the adverse effect of these anticoagulants? That they have bleeding disorders. So the best way to induce a prophylaxis is with heparins, either non-fraction or the newer one, which is a low molecular weight heparin. Now there are the newest medications. They are the inhibitor of factor 10 activated, which is rivaroxaban. And we have fewer adverse effects, and this is great because we give them orally once a day. So this has been a revolution in the anticoagulant therapy. So when do we use them? If the patient is on anticoagulants, they need to suppress that for at least 2 days, and you take their clotting times. And you assess your patient. If your patient is not overweight and is not smoking and is not taking any medication such as oral contraceptives, then he has a very low risk of forming thrombi during surgery. But for those who are at high risk, such as patients that are very overweight or obese, and they smoke and they take medications such as oral contraceptives, or they have some sort of a neoplasia that forms thrombi. After surgery, it is indicated that you use this prophylaxis with heparin in order to prevent the formation of thrombi. So, if the case is an emergency surgery, you need to take that patient to the operation room, and you need to suspend the anticoagulation, and you need to infuse fresh frozen plasma and blood if needed. If you anticipate that the patient is going to lose an enormous amount of blood, and you administer vitamin K in bolus, all right, so that you can reverse the anticoagulant effect of the patient. That's an emergency, and let's assume that there's an extreme emergency and you have that patient on heparin. The counteractive medication of heparin is protamine. So if your patient is on heparin and you need to operate him right away, you need to reverse the effect of the heparin by administering protamine. And that's it. When you give your patient anticoagulants, how you make sure that your anticoagulant is making its effect? How do you make sure of this? Well, you measure the clotting times. And the clotting times, they have to be 2 to 3 times as high as the normal values. All right? 1, 2 or 3 times as high as the normal values. Now, if you have a bleeding in surgery, you need to assess these things. If it's a technical thing or non-technical. If you see a vessel that it's bleeding, you need to suture that vessel up. If there's no technical cause, nor apparent technical cause, and your patient is trembling and it's very cold, you need to warm your patient and the bleeding will stop. If the bleeding continues, you need to assess his platelet states and his clotting times and check his background. If you see the clotting times in normal, then your platelets are not functioning. If you see the TPT prolonged, that means that the intrinsic pathway, it is damaged. So what do? You infuse fresh frozen plasma or cryoprecipitates. If you check your INR increased, that means your vitamin K factors are deficient. So you need to infuse vitamin K. And if you have everything prolonged, you need to infuse everything. That's the way you respond to a bleeding on surgery. What do you do when you are performing surgery? Well, first, you grab your finger and you push it. You push wherever you see it's bleeding. That's the first thing you do. Then we have thermal agents, such as a cautery, or chemical agents. One chemical agent that is very useful and it's going to be very handy on your social service is the peroxide. When you press a gauze full in peroxide, that's a chemical agent that will produce vasoconstriction and the bleeding will stop. That, of course, if you don't see any vessel that is ruptured. But if you have a vessel that is ruptured, you need to make your sutures. So you can patch it up. Either you use clampings, you use clips. There are many things available in surgery so you can stop the bleeding. Now the tourniquet, I'm going to leave it here as a question mark because we don't use tourniquets anymore unless you can identify which vessel is causing the damage. And in that way, you're going to press directly into the vessel that is bleeding. That's the That's the best advice I can give you. And well, you have to press. See, here are some clips that we use in surgery. We don't use tourniquets. Instead of that, we apply direct pressure on the wound to stop the bleeding. And for instance, this is an gallbladder surgery. These are titanium clips to closure the cystic artery and the cystic duct, and we put some clips on it. So that keeps the vessel closed and the bleeding stops. There are thermal agents, as I told you. There are electric cauteries or cold. When the cold, I don't know if you have seen the news, there's a polar wave striking the United States. And there have been people dying from cold. But what's most important is the so-called frostbite. Have you heard of it? People are getting burns called frostbite because cold causes vasoconstriction of the extremities, and the extreme vasoconstriction then turns into necrosis and a loss of the fingers. So look for this up, frostbite. These type of lesions are very common right now in the United States because of the polar wave that's been striking them. And of course that causes necrosis and eventually the loss of extremity. You can see pictures, especially in Michigan, the Michigan Lake and Washington area. You can see frostbites in the fingers, frostbite lesions in the tip of the nose, and frostbite lesions on the ears. So this is quite common on extreme cold, but we use cold to stop the bleeding as well. This is the cautery that I just told you about. It works as burning the area, literally burning the area, burning the vessels, and you can also have this particularly smell of the tissues being burnt. There are chemical agents such as epinephrine. That's when you have an extreme bleed from the nose, what you do, you insert a gauze, a simple gauze on epinephrine, and you stick it up to your patient, and the patient will stop the bleeding. And there are some other fibrin synthetic products such as Gelflam, which is a gelatin, Oxycell, which is cellulose oxidized, Surgicel. All of these you're going to see in a surgery. How they work, it is like a synthetic fibrin that attaches to a bleeding site. Of course, it has to be a little bleeding, and they stop it. Or fibrin seal that comes liquid. Here's the types of fibrin liquid. This is a mesh of Surgicel mesh. This is a fibrin synthetic mesh, and it stops the bleeding. Of course, it has to be not a large bleeding or not a vessel that you can see wide open. You can use all of this. Now, how do you do your prophylaxis? Have you seen those patients that are going to be operated, especially in public systems, that the nurse put them some bandages on the legs? Have you seen this? Well, they use this in order to prevent the stasis in the legs. So the bandages causes to apply some kind of pressure in the legs. So then you have an anti-thrombotic measure to prevent hemostasis of the blood. So if you do this, you're applying an anti-thrombotic measure. And what do you do after the surgery? You get your patient to walk as fast as, not walk very fast, but you try to get them up, not just lay down in bed. We need to make them move their legs so they can have a little walks as soon as possible. That means early walking. Now, aside from the bandages, on private hospitals, you can see these pressure stockings, and they're very useful. And if your patient is very obese and very fat, we have these intermittent compression system, which is a pair of bandages that are attached to a pump. So eventually this pump will work intermittently, and will make like the leg was walking. So you make that your prophylaxis. If you suspect that your patient, it is a great risk of forming thrombi, you need to start him right away after surgery some form of heparin. Which cases are these? Remember, these obese patients or overweight, patients with cancer, patients with a history of smoking, and patients that are taking medications such as oral contraceptives. Be aware of these because they make thrombi. And which is the complication of making a thrombi? That make a pulmonary embolism. That's why. So, any questions so far? All right. That's it. That's it. The rest of the presentation, we're not going to see that. I just want you to be very aware that you have to prevent this. You have to watch out for those patients who are at risk of making thrombi. And there are measures that you can take, non-medical, non-pharmacological, and pharmacological, and how they act. All right? So you need to ask your patients to stand up as soon as possible and to start early walkings whenever they can. All right, so I'm going to switch now to another subject, which is shock. It is very easy, fairly easy. It doesn't get that complicated. By the way, there will be a test. Of course, I'm going to give 2 weeks for it. And then about shock, you're going to do your next assignment, which is a mind map. All right, can you see the presentation? No? Yes? All right. This is very easy. The shock definition, you have to recognize it. That's all I'm asking for. You have to recognize when a patient is in a state of shock and act immediately. The definition is the imbalance between oxygen perfusion to the tissues and the demand of oxygen by the tissues. That means low perfusion. Low perfusion equals shock. All right, so your tissues are requiring some sort of oxygen, and normally the oxygen supply, it is more than enough. But in a state of shock, this reverses. The oxygen consumption is greater, far more than the oxygen that is being delivered to the tissues. So what happens then? All of your tissues are in lack of oxygen desperately. So all of your body starts falling into shock. Now, what happens if you don't have enough oxygen? Then your cells are not going to have enough oxygen. They're going to be low in energy, and they will switch their metabolism to anaerobic metabolism, which then will produce lactic acid. The pH will fall and cause metabolic acidosis. And as you can recall, metabolic acidosis switches the hemoglobin dissociation curve. That means that the hemoglobin will attach more or stronger to the oxygen, and it's not going to release it that easily. After that, all of the pumps, the sodium pump is going to start failing, and the intracellular lysosomes will be released, and all of the cells will be destroyed, releasing toxic substances to the circulation, causing the endothelium to have leakage. That means it's going to lose the ability to contain the volume into the intravascular space, and it's going to lose it into the interstitial space, and eventually this will cause destruction, dysfunction, cell death, and eventually death itself. So we have to recognize the early stages of shock. The early stage is that everything will start failing. How do we do that? How do we see that? Well, our heart is going to start diminishing his cardiac output we're going to see that by hypotension and myocardial depressants. The lung is going to diminish the gas exchange, and we're going to see that through tachypnea and pulmonary edema. The endocrine system is going to fail as well, increasing the antidiuretic hormone, which then in turn will try to increase the reabsorption of water. The central nervous system is going to be very bad perfusing, so the patient is going to feel drowsiness and the loss of consciousness eventually. Now, in the blood, we're going to have coagulation abnormalities because our blood flow won't be the same. The renal function, of course, is going to be deteriorating, diminishing the urine output, and everything will be damaging. What's there to know? That we have to assess our patients very fast and then identify the type of shock and the degree of shock that the patient is in, and act accordingly. We have very a variety of types of shock. We have a hypovolemic shock that can be either due to hemorrhagic shock or non-hemorrhagic, such as burns. We have the cardiogenic shock that comes because of the failing in the heart as a pump. Is not pumping as it should be. We have respiratory that comes from the cardiogenic. We have the other one that is distributive shock, and we have distributive because it switches the intravascular volume, loses the attachment between cells. So we have a lot of volume lost into the third space, such as septic shock, neurogenic shock, and anaphylactic shock. The obstructive shock, we're calling this specifically the tension pneumothorax or cardiac tamponade, and we have to act very quickly. These can be seen on a trauma setting. So after identifying the type of shock, we need to act very fast, immediately. The hypovolemic, as I told you, is the loss of volume. either due to hemorrhage or the loss of volume due to diarrhea, vomiting, and secondary dehydration. What do we do in hypovolemic shock? Well, if the patient is bleeding, we need to stop the bleeding. If your patient has diarrhea, you need to stop the diarrhea. And in both cases, we need to rehydrate our patient. And that's how we stop the shock. In cardiogenic shock, there may be something wrong with the valves, or the patient had a heart attack, or an arrhythmia, or a disease such as cardiomyopathy that makes the heart not pumping sufficiently or optimally speaking. The obstructive is in a trauma setting such as cardiac tamponade, and in cardiac tamponade we're going to see the Beck's triad. And the Beck's triad, that means we're going to have hypotension, jugular distension, and ruffled or absent heart sounds. If we find this clinically, then we have a cardiac tamponade. Then we have a pulmonary embolism, which is a mismatch of the ventilatory circulation equation, or the tension pneumothorax, or an air embolism. The neurogenic shock, any trauma that presents to the spinal cord. Now, careful with this. The neurogenic shock, you need to suspect that from the trauma, but in this case, we're going to have something very, very unique, that the patient is hypotensive despite of volume infusion. So no matter how much volume you infuse to this patient, you don't see any blood loss, and you see your patient that remains hypotensive. So you need to start vasopressors. That's a unique characteristic of this neurogenic shock. The anaphylactic shock is an allergic reaction that most commonly causes is penicillins, or some anesthetics, or some stings, or shellfish. What do we do? Well, we stop the allergic reaction. How do we stop that? We have to give a steroid quickly. The shorter half-life steroid that acts very fast is dexamethasone. And we have to give antihistaminics. All right, so we have to stop that immediately. The septic shock, this is a quite common cause, and you need to be aware of this. Before the patient falls into shock, he started to develop an infection with the SIRS. That means a syndrome of response to the inflammatory response. That means your patient is tachycardic, hypotensive, it has fever, it has either leukocytosis or leukopenia if the infection is advanced, and you have to suspect that. In diabetic patients, please remember this. In a diabetic patient on an emergency setting, you have to assume that the patient is infected until confirmed otherwise. All right? Make sure about this. And you have to look for the cause. You have to start. What's the treatment in here? Well, if you don't know where's your primary infection, you have to start on empiric, broad-spectrum antibiotics. And you have to take cultures from whatever, the urine, the sputum, whatever secretion the patient has. You need to be aware that it's not infected. So careful with this. So you have already all the types of shock. But there are degrees of shock in these types. You may have a mild, a moderate, or severe shock. But in either case, you have to identify them quickly. What are the clinical characteristics? Well, first, if it's a mild shock, the extremities are going to become a little cold because of the vasoconstriction. The pulse rate may be normal. The blood pressure may be normal. And it's a bit hard to recognize up to this point that the patient is in shock, but you have to be aware that he may be developing one. In moderate shock, you're going to find out this clinical scenario very much profound, such as your patient is unconscious or feeling dizzy or sleepiness. Your patient is not making any urine, and it is already tachycardic, hypertensive, and if you don't act quickly, this will evolve to the next step, which is severe shock. Now, in severe shock, your patient is not responding at all. Is very cold. Is not urinating anything. His pulse is very rapidly, and he has a profound hypertension, so profound that it may not even be heard at all. So, what stages do we have? In all types of shock, we have the initial state. The initial state, that's when the endothelium lacks the continuity between their cells, and the endothelium starts to be, or to leak out the volume. So you start losing the volume from the intravascular to the interstitial space. Now, if you correct this, then you fall into the non-progressive stage, which is the compensated stage that the organism or the body tries or attempts to get out of the state, such as making your heart beat faster so that you can recover your hypertension. It switches off the circulation to the non-vital organs, and at this point it can be reversible. The progressive states is that when everything is falling apart, all of the systems, every system is shutting off. The kidneys, the heart, the liver, everything is falling apart. Up to this point, there's nothing you can do, or very little. So we have to act quickly. And refractory, that means that, well, it's just one step behind death. That means every organ has already failed. There's no turning back up to this point. So you see here, if you see some early signs, like your patient is cold, it looks a bit pale, it has a slightly increased respiratory rate, or slightly decreased body temperature, you need to act quickly. But let's assume that your patient arrives in late signs. You need to act quickly, and you need to reverse this. If no measures are taken when you see late signs of shock in your patient, then your patient is going to die. Now, what's that? The difference between the late two stages is that in decompensated, you start seeing that your organs begin to fail. They begin to fail. And at this point, if you act very aggressively, you can reverse this. But in refractory period, or in refractory stage, all of the organs have already failed. None of them are working. Up to this point, the damage is irreversible, and there is a very, very, very low, statistically speaking, low chances of surviving. That's what we see here. If we see a decompensated stage with late signs, that means your patient's cold, pale, it has tachycardia, very profound hypotension, you may act along because he may be falling into an organ failure. He may begin organ failure. But when you detect more than 2 organs that have already been failed, then you switch to the irreversible shock. What do you do when you check your patient? You check the blood pressure, the heart rate, the respiratory rate. You check everything. Everything. You need to, these patients, they come into the intensive care units. So what do we check? Everything. Everything by the hour. What are the special monitors? The central venous pressure that goes into the right atrium. It needs to go, normally speaking, between 5 and 10. If it's below 5, we're talking about we're not putting enough volume to the patient. If it's beyond 12, then we are overloading our patient in volume and the heart pump is not functioning. We can measure the catheter insert of the pulmonary artery to measure the wedge pressure. That it gives us an indirect pressure of the left ventricle. Of the right ventricle. You can do as many tests as necessary. I'm not going to ask this on the test, but it is important that you may recognize the shock, what types of shock are there, and to assess the clinical scenarios. If your patient had been on a car accident, you need to assume that the patient is in shock until proven otherwise. Otherwise, you're going to be missing that. If your patient is diabetic and arrives to the emergency department feeling sleepy, tired, a bit dizzy, he's not urinating very well, you need to say that right there. Your patient is beginning with septic shock. You need to find the source of infection right away and start on reanimation. What's reanimation? You need to infuse volume, depending on the shock. But on septic shock, you need to infuse volume, check his pH. You need to provide him with oxygen, because this is very important. And you need to act accordingly. Otherwise, you're going to sit your patient and you're going to say, all right, sit there, sit back, and let's wait until the results are back. You're wasting time there. And what any other? Well, you make your blood gas analysis to check for the pH, the lactate, and very importantly, you need to check if your patient, how much your patient is urinating. The best way to assess that is to insert a Foley catheter and measure everything. How much is it going to be enough? The patient has to urinate at least 1 milliliter per kilogram per hour. If it's urinating less than that, we're talking about oliguria. If it's not urinating anything at all, worry because your patient is starting with organ failure. Check out for the urine. There are no written things in here. You have to treat the main cause in order to stop the source of shock. You need to improve the cardiac function at all times, and that will ensure that the tissue perfusion remains optimum. Sorry. Are there any questions so far? So it's not that difficult. The overall goal is to increase the oxygen to the tissues. That's it. Whatever you need to do it. But you need to assess your patient first. And I'm going to emphasize it here. You remember that your patients are not going to arrive with a diagnosis on their chests. You need to make it on your own. And when you see a patient that arrives to the emergency department feeling dizzy or feeling like he wants to sleep, careful with that because he's not getting enough oxygen. If suddenly a family member tells you that the patient is being aggressive and he normally isn't, be aware of this. That is telling you that there's some lack of oxygen in the central nervous system. So you have to look if he has any other clinical signs that will make you suspect that your patient is in shock. Why do I tell you this? Because unfortunately, I've been witnessed hundreds of times that physicians, even specialists, they missed the shock diagnosis, and when they found out that the patient had been in shock, guess what? It was already late, especially in public places. Be aware of this and suspect it. What do you check? You need your patient to breathe properly, so you give him oxygen. If he's not breathing or if he can't breathe, you need to intubate him. You need to place him into the IV access and start making your fluids infusion. What type of solution? You already know this. You need to assess the cardiac function, and you need to assess that your patient is receiving enough oxygen. What kind of solutions? You already know this. What kind of solution is forbidden? The colloid solution. We will be talking about a blood transfusion on a trauma setting. We're not going to see this here, only that you know that in some instances we have to use blood transfusions. And well, that's it. You already know about this. If your patient doesn't have enough blood, he's not going to be carrying any oxygen nowhere. So if your patient lost a lot of blood, you need to infuse him blood so that he can improve his oxygenation state. Questions so far? And the final thing, when you address your patient and you start infusing volume rapidly, and your patients start responding, as I told you, the class before that, then you see the improvement, so you say, okay, this patient is a responder. So I already acted on the cause and I'm making my patient better. But if your patient improves a little and then goes back to be bad again, then you are in front of a transient responder. And this means that the damage is still out there. So you have to look for it. So if your patient gets better, but then goes back again to feel bad, he's a transient responder. You have to look all aware for the cause. And there are patients that are non-responders. Watch out for these, because these are very serious cases. And I mean very serious, but most of them are trauma settings. On trauma settings, there are patients that they're so, the type of trauma was so severe that they almost died in the car accident or in the car crash, and they will not respond to treatment. That's it. And vasopressors when needed, especially on septic shock and neurogenic shock. Those patients will not respond initially to volume, to just volume. So what do you do in order to increase the blood pressure and therefore the cardiac output? You need to infuse vasopressors, such as noradrenaline or vasopressins. If it's a cardiogenic shock, you need to address the pump function, and in those cases, you're going to see that the physician infuses the butamine. That increases the inotropic effect and the force. I mean, it increases basically the force on the cardiac pump. That means that you can use this in cardiogenic shock. I don't want you to learn this. This is just a scheme for you to see that whatever it takes to get that patient out of shock, you have to use it. You have to do it. Questions? Your next assignment, you will have 2 weeks for that, another 2 weeks from Tuesday. You will have to do a mind map of shock. You can do it by hand or in a software or in your computer, but it has to be creative, all right? This is a simple subject for you to be creative at. Any other questions? Carlos, yes, both quizzes are for the next week, next Sunday. For February 10th, that's right, Danny. All right, thank you all for being here. Have a great weekend. If you drink, don't drive. Please don't drive if you drink. Don't drink too much. Have a nice weekend. Bye-bye.